Good afternoon. I would again start by thanking the organizers for inviting me to give this talk. And over the next few minutes, I will go through how to prevent or avoid hepatitis B complications. I will talk about preventing infection, preventing transmission to others, preventing disease progress, preventing hepatocellular carcinoma, and preventing reactivation very briefly. To prevent infection, vaccination prevents infection. This is a fact that has been proven for the past 30-something years. And an excellent example of preventing infection and getting rid of the disease is Saudi Arabia. 10 years after the introduction of vaccination, the prevalence of hepatitis B in vaccination-age children dropped from 6.7% to 0.3%. And this table shows the prevalence in different areas of Saudi Arabia before the vaccination program and 10 years after the vaccination program in children. So vaccination prevents disease. Hepatitis B has almost gone in everybody of the vaccination age in Saudi Arabia. And vaccination prevents infection and prevents hepatocellular carcinoma. Studies from East Asia, from Taiwan and Korea, showed that the incidence of hepatocellular carcinoma before vaccination dropped tremendously after vaccination in Taiwan, in children, and in adults in Korea, dropped by from 18 per 100,000 to less than 1 per 100,000. So again, these graphs show the decrease in hepatocellular carcinoma related to hepatitis B and mortality related to hepatitis B after 10 years after vaccination. And this was the first proof of a human cancer preventable by vaccination. So you can avoid and prevent liver cancer by hepatitis B vaccine. And you can prevent transmission to others. You have to screen all contacts of a case and vaccinate all susceptible contacts. And importantly, you have to prevent transmission to newborns. Mother-to-child transmission is preventable by giving treatment during the last trimester of pregnancy. Studies initially with lamivudine and more recently with tenofovir dipivaxil compared to placebo, in addition to hepatitis B immunoglobulin and vaccine to the newborn at birth. The incidence on the tenofovir arm was 0. And in the in the placebo arm who got the HBV and the vaccine only close to 2%. And more recently, all studies that evaluated tenofovir alafenamide compared to tenofovir dipivaxil showed that they are both equal in preventing mother-to-child transmission with 0 transmission with both. Can we prevent disease progression? The REVEAL study more than 20 years ago have shown that among untreated patients with hepatitis B, including 43,000 person years follow-up over 13 years, the disease progress and progression to cirrhosis was related to the level of the hepatitis B DNA at baseline. The higher the DNA, the more disease progress, and the higher the DNA, the more HCC incidence. So having a high hepatitis B DNA predisposes to progression to cirrhosis and HCC, even in patients who are E antigen negative and even in patients who have continuously normal ALT. So the CALM trial was a landmark trial comparing treatment with lamivudine to no treatment in patients with cirrhosis to prevent decompensation and prevent disease progress. It showed that disease progression was much lower on lamivudine compared to placebo. Increase in child score was much lower with lamivudine compared to placebo, and developing HCC was much lower with lamivudine compared to placebo. So this was the last trial that patients received placebo, and treating hepatitis B became standard of care. And on lamivudine, the lower the DNA level, the more prevention of hepatocellular carcinoma. So if you suppress the DNA very much, you get much less incidence of HCC in patients with cirrhosis. In Taiwan, they compared 21,000 patients treated with different treatments, entecavir, lamivudine, or telbivudine, compared to 21,000 patients who were not treated. And HCC was much lower with the treatment, with all treatments, compared to no treatment. So now, should we use entecavir or tenofovir to prevent HCC in patients with hepatitis B? A national study from Korea showed that treatment with tenofovir resulted in less incidence of HCC compared to entecavir in the nationwide cohort and in the validation cohort. And a meta-analysis that included 35,000 patients also showed that tenofovir resulted in 75% and 25% less HCC compared to entecavir. However, many reports have been published, and they all concluded that entecavir and tenofovir are equal in preventing HCC. So we can use either entecavir or tenofovir in patients with hepatitis B to prevent HCC. Should we prevent HCC in immune-tolerant patients? In a trial in Korea, they compared patients who are immune-tolerant, who did not receive treatment as the guidelines stipulate, to patients who are immune-active on treatment with nucleoside analogs over a 10-year follow-up. And in untreated immune-tolerant patients, the incidence of HCC was higher than treated immune-active patients. So treating patients prevents HCC, and they suggest that starting antiviral therapy in the immune-tolerant phase is cost-effective now with the lower prices of tenofovir and entecavir. You can treat everybody, and they are suggesting that all patients should be treated. So should we treat all patients to prevent hepatocellular carcinoma and hepatitis B? This needs further studies, and the current guidelines, all the guidelines, do not indicate treating immune-tolerant patients. However, this can be reconsidered in the future. To prevent HCC in patients with liver disease and hepatitis B, coffee is preventive, and a large meta-analysis in the UK showed that included more than 2 million participants, that drinking coffee prevents HCC, and the more coffee the patient drinks, the more prevention of HCC. Drinking 2 cups of coffee a day leads to 35% reduction in risk. And a recent biobank study showed that the more cups of coffee the patient drink, the more prevention of HCC. So you should suggest or recommend coffee drinking to all patients, and the more coffee they drink, the better. And a recent study from Sweden that came in the New England Journal of Medicine 2 years ago compared persons or patients receiving aspirin to patients receiving no aspirin over a 10-year follow-up. And it showed that low-dose aspirin significantly lowered the risk of HCC without increasing the risk of GI bleeding in patients with liver disease. Can we prevent reactivation of hepatitis B? Using cytotoxic or immunosuppressive therapy is usually followed in untreated patients with a flare after withdrawal. And this is a typical case, a patient who was surface antigen negative, DNA negative, started CHOP treatment for lymphoma. After several cycles, after the end of therapy, at the end of therapy, the DNA turned to positive. And after a lag period, a month or two after stopping therapy, there was a flare in ALT and a flare in bilirubin, and the surface antigen reverted to positive. This was treated with nucleoside analogs, and the patient luckily survived, but flares can be severe. The incidence of flares or reactivation with chemotherapy, with CHOP therapy, if the patient is surface antigen negative, anti-core negative is 0%. If the patient is surface antigen negative, anti-core positive is 4 to 5%. And if the patient is surface antigen positive, is close to 50%. So all patients who have been exposed to hepatitis B should receive chemoprophylaxis or nucleoside analog prophylaxis when starting therapy. And current National Committee guidelines for hepatitis B state that all candidates for chemotherapy should be screened for surface antigen, anti-S, and anti-core. And if the surface antigen is positive, regardless of the viral load, they should receive entecavir or tenofovir with the initiation of therapy and for 1 year after end of treatment. If the anti-core is positive and the DNA is positive, even if the surface antigen is negative, they also should receive prophylaxis. If the anti-core is positive and the DNA is negative, they should be followed every 3 months and starting treatment if the DNA turns positive, even before a flare, to prevent a flare. So in conclusion, most hepatitis B complications can be avoided. Vaccination prevents infection, prevents disease, prevents hepatocellular carcinoma. We can prevent mother-to-child transmission. Treatment decreases disease progression. All hepatitis B patients should be on treatment and decreases HCC. And continuous surveillance of HCC is mandatory even after with successful treatment. The patients should be screened, and even if they are immune tolerant. And reactivation can be avoided with treatment. And thank you very much for your attention.